guys all know me, I'm Stephanie. All right, I'm going to be talking about the use of long-term anticonvulsants after alcohol withdrawal seizures and how effective they are at preventing future seizures. Learning objectives, understanding the pathophysiology and timing of alcohol withdrawal seizures, exploring the use of anticonvulsants in alcohol withdrawal seizures and the evidence supporting or against this, discussing the utility of using anticonvulsants to reduce symptoms of alcohol withdrawal, and then to describe when the use of anticonvulsants in alcohol withdrawal seizure is indicated. So a little bit on the epidemiology of alcohol use disorder. Currently affects about 18 million Americans and will affect approximately 30% of the US population in their lifetime. Globally, alcohol use disorders are thought to cause approximately 5% of all deaths, and up to 40% of patients who are hospitalized have alcohol use disorders. It is estimated that 9 to 25% of status epilepticus cases are from alcohol withdrawal, and the total economic cost to the U.S. is estimated to be about $235 billion annually. And here's a nice chart on our local community and the rates of binge drinking. Got this on our Cottage website here, or the population health website. So as you can see, the lighter blue, so that's about 10 to 19% of the population above 18% did admit to binge drinking, and that is considered 4 or more drinks on one occasion for women and 5 or more. So this light blue, 10.3 to 19% is the range, and you can see that there's lighter blue kind of in the more affluent areas. And then as you go going down or up the darker colors, then you have more alcohol use disorder. See a lot in Isla Vista, and you see a lot over here in the coast here near the funk zone. This over here is Santa Maria, looks pretty dark, and then Lompoc over here, pretty dark. A little bit on the pathophysiology of alcohol withdrawal seizures. So alcohol causes intoxication through the effects of GABA A receptors and NMDA receptors. Alcohol dependence results from compensatory changes during prolonged alcohol exposure, including downregulation of GABA A receptors. Withdrawal seizures are believed to reflect unmasking of these changes and may also involve rapid increases in GABA that causes a reduced inhibitory function, leading to a seizure. The number of GABA A receptors correlates directly with inhibitory strength. So when alcohol is withdrawn, its potentiating effects are no longer present. So you have a reduction of GABA A receptors, impaired inhibition, and then it predisposes someone to a withdrawal seizure. And you can see here, when someone is in homeostasis, non-alcohol, GABA and NMDA pretty balanced. Intoxication in an occasional users causes GABA to be upregulated, and NMDA kind of stays around the same, and you have more CNS depression. For a chronic and regular alcohol user, they're also a little bit more in homeostasis, with the GABA being downregulated and the NMDA being upregulated, a little bit more towards this side. And this is what happens in alcohol withdrawal, where your GABA is downregulated and your NMDA is really upregulated. So you have CNS hyperexcitation leading to a seizure. Timing of alcohol withdrawal, I think we all kind of know this pretty well, but between the first 6 to 12 hours after the last drink, you can expect some insomnia, some tremors, anxiety, diaphoresis. 12 to 24 hours later, you can have some visual and auditory hallucinations. 24 to 48 hours is really where you start seeing these withdrawal seizures, and then 48 to 72 hours after, you can see DTs and agitation, which you can kind of see throughout. Management of acute alcohol withdrawal. So the use of anti-epileptic drugs after an alcohol withdrawal seizure has been controversial in the past. In the US, benzodiazepines are considered the drug of choice to treat alcohol withdrawal and to prevent the occurrence of seizures. But in Europe, there's been more carbamazepine, chlormethiazole, and valproate used. And anti-epileptic drugs such as Keppra, carbamazepine, phenytoin, valproate, and they've also studied vigabatrin, which I hadn't heard before, which is a GABA transaminase inhibitor. Starting with some of the studies that I found, this is a pretty old one, so I'm starting with it. And there was a lot before the 90s, I think, where they did more like experimentation with like placebo versus an anti-epileptic. Like in this case, there was 138 patients randomized into 3 groups. 46 are receiving valproate, 43 received carbamazepine, and 49 received placebo. Primary outcome was seizures and delirium. They didn't report statistical significance, but based on these numbers, 1 out of the 46 patients on valproate had a seizure, 2 out of 43, and then 3 out of 49 for placebo. So those are all pretty similar in numbers. Phenytoin, have a few studies here also from a little bit ago. We have this first study by Rathlev, who studied 100 adults presenting with alcohol withdrawal seizure. 49 of them received phenytoin, 51 of them received normal saline placebo. The primary outcome was a post-infusion recurrence of seizure within 6 hours. 20% of the patients in the phenytoin group had a repeat seizure, compared to 23.5% of the normal saline group, and it was not statistically significant. Chance, 1991, had a similar study with a little bit smaller, 53 adults with alcohol withdrawal seizure, 28 received phenytoin, 27 received placebo, same primary outcome, and again, 21% of the phenytoin group had a repeat seizure, compared to 18.5% of the normal saline group, which was also not statistically significant. This next one, 90 adults presenting with alcohol withdrawal seizures, similar thing. We had 13.3% of the patients in the phenytoin group had a repeat seizure, and then the exact same percentage of the normal saline group. This one is a little bit newer. 2010, a meta-analysis done by Cochrane Review included 7,333 participants from 114 studies. All patients experienced alcohol withdrawal symptoms, regardless of the severity of the withdrawal manifestations, and included both inpatients and outpatients, looking at the primary outcome of alcohol withdrawal seizures. And then any anticonvulsant, as listed right there, included all of these medications. So depending on the study, there was different medications, but phenytoin, diphenyldentoin, chlormethiazole, thiapride, gabapentin, valproate, carbamazepine, and oxcarbazepine were used. And we can see here the the number of seizure occasions in the anticonvulsants group and then versus the placebo group. They're pretty similar. 6 patients here, 5 on the placebo group, 6 compared to 6 for this study, 1 compared to 3 for this study, 10 to 12, and then if you look across here, they're all very similar here. And then this one, I don't know why they liked phenytoin so much back then, but they did phenytoin, and same thing, 6, 5, 10, and 12, 6, and 6. And this one is a little bit of a outlier, where you had 0 out of 70 on the anticonvulsant group have a seizure, and then 11 out of 66 here. But overall, you can see that there's not a huge difference. Rojo Mira in 2022 had a meta-analysis, included 1,700 patients, 26 different studies, randomized control trials comparing the use of an anti-epileptic drug and a benzodiazepine versus a benzodiazepine alone versus just placebo. Primary outcome is the improvement in symptoms, DTs, seizures, and adverse effects. Anticonvulsants in these studies were these following, so kind of similar to the previous. And the use of anti-epileptic drugs did not represent significant decreases in the incidence or recurrence of seizures. And seizure was present in 18.5% of patients receiving anticonvulsants versus 19% of patients receiving placebo. So you can see here again, number of events, number of control events, and they're all kind of similar. 6, 5, 45, 39, 1, 1, 0, 5, 10, 12. Total events for this group compiled 69. Total events for the control group compiled 71. And that was also not statistically significant. Lycock Roberts, this one is 24 randomized control trials, 2,000 patients, all with alcohol use disorder, looking at the same thing, alcohol withdrawal and delirium. No evidence to support general first-line clinical use of anti-seizure medication. Seizures present in 9.5% of the participants receiving an anticonvulsants, compared to 11.2% of participants receiving placebo. Again, not statistically significant. And then this study is looking a little bit less at alcohol withdrawal seizures, but I just thought it was something pertinent to bring up for us, especially gabapentin. So they looked at it here in 2020. There was 90 patients, double-blinded randomized controlled trial. They were randomized in the gabapentin group versus a placebo group over a 16-week treatment period. They used an alcohol withdrawal score, which they are looking at. It's like a kind of individualized checklist where people check off if they have nervousness, sweating, tremors, nausea, vomiting, seizures, hallucinations, confusion, chills, headache, and sleep disturbances were the points looked at. And they found that those with high alcohol withdrawal scores from this survey they did had less relapse to heavy drinking and more abstinence when treated with gabapentin than those with low alcohol withdrawal scores, where they didn't really see any differences in relapse to heavy drinking or abstinence. And you can see here in the gabapentin group and then the placebo group for people with low alcohol withdrawal score and high alcohol withdrawal scores, whereas the low alcohol withdrawal scores are pretty similar, but the high alcohol withdrawal scores are having less of these heavy drinking days, as well as less of these days, or more of the days abstinent, and those were also statistically significant here. This last one is something also that I thought was curious, looking up at phenobarbital, and this was a meta-analysis of 12 studies, randomized controlled trials, and observational studies, 1,900 patients who presented with the ED with alcohol withdrawal symptoms. The primary outcome was the rate of intubation among patients who received phenobarbital compared to those who received benzodiazepines. And they found that 765 patients were treated with the phenobarb, and then 11,169 were treated with other modalities, which included a bunch of other medications. But treating alcohol withdrawal symptoms or patients with phenobarbital did not increase their risk for intubation. And the patients who were treated with phenobarbital were found to have similar rates of seizures and length of stays in the hospital when compared with patients receiving benzodiazepines. Which is kind of interesting, I thought. So should any patient with alcohol withdrawal seizure be started on anti-epileptic drugs? The goal is to avoid precipitation rather than to provide long-term prophylactic anticonvulsants. But in a patient who's having frequent or prolonged seizures, long-term anti-epileptic drugs could be justified. However, the patient needs to be adherent. And I was trying to find studies that studied this, like outpatient use of anti-epileptics in people who have had prolonged seizures or more than one. Couldn't really find anything, unfortunately. But I think it's really important to, relate to our patients if we are going to start them on an anti-epileptic, that it's extremely important for them to be adherent, and sometimes that could be difficult if someone is still actively drinking. If there is a possibility of an unprovoked seizure, then long-term anti-epileptic drugs are indicated, and newer anti-epileptic drugs like Keppra, lamotrigine, topiramate have limited drug-to-drug interactions and few or no hepatic effects, which could be good for our patients. And in hepatic impairment, we want to make sure to avoid carbamazepine, phenytoin, and phenobarbital.
Anybody have any questions? Stephanie? Dr. Bookspan?
Is this only related to during alcohol withdrawal or continuous after the alcohol withdrawal is done?
So that's what I was trying to find studies that have looked at after alcohol withdrawal is done to see if there's any indication for like chronic alcohol withdrawal seizures, and I couldn't find anything with good data on that. Most of them were looking at acute.
Again, the fact is that benzodiazepines are good anti-seizure medications. So without knowing what the benzodiazepine dosing is, it's hard to really extrapolate from these studies into long-term studies. And clinically, I think we have problems if someone has recurrent seizure activity, but they're a chronic alcoholic and they're drinking all the time. How do we really know whether they have an unrelated seizure focus or it's only triggered by alcohol withdrawal? I think that's a clinical problem that we all face. But I don't know how to use this information without knowing what the benzodiazepine dose was and which agents were used, because the problem is not all benzodiazepines have the same biologic half-life. So if someone is on the downslope of being loaded with a benzo, it actually triggers seizure activity, whereas if you're using a long-acting benzodiazepine, it should help treat and prevent seizure activity.
I don't remember the dosing because they were all kind of different, but I think the main benzo used in these studies was Librium.
I think that the benzo dosing is obviously variable depending on the patient, and a lot of these, they basically, when I looked at some of these studies, they were just comparing it to usual care. So, it was up to the clinicians to decide whether they needed more benzos or less benzos. The type of benzo was selected by the individual clinicians. They weren't really randomizing or looking specifically at which benzos. They kind of lumped them all together. I think in general, Valium and Librium were the most commonly used, I think, for these studies, but yeah, there's not much data on that. Yeah.
Maybe just to piggyback off that, did you get a sense, Stephanie, so you made a comment, you wondered why everybody's focused on penicillin in 2010, looking retrospectively, and I think it's because there were limited options, in the decades before that study. As you looked carefully at this, and to piggyback off Dr. Bookspan's point, because there's been a shift towards benzo-sparing alcohol withdrawal regimens, I wonder if you got a sense that it was a difficult question to ask because the landscape around inpatient treatment of alcohol withdrawal has been a bit of a moving target.
Yeah, and it seems like the newer studies too are, we know benzodiazepines can prevent seizures, so there's a little bit of a ethical thing also going on. We're just doing placebo for these patients, and something interesting I found regarding gabapentin is that I didn't find any studies really saying that it prevents alcohol withdrawal seizures, but there were a few promising studies that showed that the benzo use did decrease with gabapentin.
Is there another question?
Well, I have a question about, you have a lot of data with these patients and they're doing a lot of the comparisons. Do you think that the patients were adequately matched for the amount of symptoms that they were having? Because if you're comparing did they have your outcomes show one set of data, but do you know if the studies talked about that at all, or if that was a limitation in the way you can interpret those non-significant differences?
It was often a limitation that was listed. A lot of the times it was just a patient with alcohol withdrawal seizures in the past, or they didn't really look at other past medical history. They didn't look at socioeconomic things. It was just kind of these patients have alcohol withdrawal seizures or a syndrome depending on what study, and this is what we found. So it was often a limitation.
I think in general in the meta-analyses that she presented, the authors of every one of those commented on the poor quality of most studies. Of course, you could say that about most things that we do. So that's why they try and do the meta-analyses, to try and filter out or negate some of those things in supposedly randomized trials. But who knows? It's the best we can do. This is the best evidence that we have at this point. So, all right. Well, I think it's any other comments before we vote? I forgot to mention that April, I found out this morning, is Alcohol Awareness Month. So this was a good topic to be presenting.
Didn't know that.
Did you know that?
No.
Okay. Okay. So is it a myth adding anticonvulsants to usual care, benzos, whatever, for acute decreases withdrawal seizures in patients being treated for acute alcohol withdrawal? So how many people think this is true? How many think it's plausible? How many think it's busted? Okay, I think most people think it's busted. Do we want to do that again? Plausible, how many were there? Wow, we're up to, people are increasing their plausible. And how many think it's busted? Wow, all right. All right.